Thank you. Thank you for the kind words. And the success of the conference actually can be judged by Dr. Gagan Saini's. I just read a WhatsApp message by Dr. Gagan Saini. He has actually ditched a breast cancer conference for the lung cancer conference, and that to mesothelioma. So thank you, Dr. Gagan. Your comments on this?
Well, I had prepared harder for this, maybe.
Yes, that is what I was coming to, So Gagan like challenges. Gagan, if you can actually think about giving radiotherapy in a patient of mesothelioma, you can actually convince me to give radiation everywhere. So I would love to have you also as a part of the panel discussion. If you can stay, I'm sure Dr. Kapoor is always there to help the cause of radiation oncology. And Dr. Devyani, I must compliment you. I just joined in the last some time of your talk, and the talk was very nice. So congratulations, and looking forward to interacting with you.
Thank you so much.
So panel discussion on mesothelioma. As every time, my first reactions when I first said yes, first of all, I should stop saying yes to everything which comes about from Ashay Karpai. He sent me a mail, I said yes. And then yesterday when I looked upon it, I said panel discussion on mesothelioma at 9 o'clock on a Saturday night. And ye kya ho raha hai? Where exactly are we going on to? What exactly is happening around? And I'm sure everybody would be yawning away to glory right now over there. I mean, at least if not everybody, I was yawning at the time at yesterday night when I was preparing for the talk. My subsequent reactions at that time basically was to try to keep everyone awake. I mean, whether it implies putting something over there or making some good learned discussion, I'm sure we'll have a good discussion is to do that. And I hope I'm able to, fulfill my obligation. So let's start with the case. This is a case scenario of 45-year-old male. This is a real case because I show you some, this is the patient which you treated. He basically comes with a history of cough with breathlessness. X-ray chest shows a right-sided massive pleural effusion. CT scan chest was done, which basically did a massive right-sided pleural effusion with underlying lung collapse. Pleural fluid cytology outside was suspicious for atypical cells, and ICD was inserted. Pleural biopsy was done, which said extensive necrosis with atypical cells. Now, this is exactly, this is my discharge summary. So I'm just showing you, this is not a something case which I'm cooking up. Everything same. CECD was done on 21st. X-ray chest, ultrasound abdomen, brush smeared nodular pleura, some atypical cells. Pleural biopsy, atypical cells, cytology, atypical cells, IHC not done. And this is what the investigations basically are. So how commonly, I'll start with you, Dr. Devyani, have you seen this sort of a scenario, and what would your first reactions be?
Thanks. Yeah, I think the scenario is extremely common. And if we were to think of the most common etiology for a patient coming to a cancer hospital with this kind of presentation to the thoracic unit, you would think in terms of adenocarcinoma. But with this kind of a massive effusion, which with repeated cytologies coming back just atypical, but with no this thing, I would like to see the imaging to see if it fits into something else.
So imaging CT scan was done, which basically I'll show you I don't have the images, but I have the PET scan report actually, which again showed only some pleural thickening going on over there, and that's it, nothing else actually. So this guy is a non-smoker also. Can I go to my medical oncology friends, Dr. Abhinav and Dr. Tanmay? What is your, how would you approach this patient? And I'll tell you what I did in the end. Burnt my fingers and everything on that.
Thank you, sir. So Abhinav here. So yes, sir, I think IHC was not done. So maybe we should consider for like repeat biopsy and with IHC studies. That would be the
this guy Tanmay has got a ICD. The lung has by and large expanded, and there's very hardly fluid. How will you do? So ICD is already there. The fluid has been drained out. The lung has kind of expanded. There's nothing to go inside. So that is what exactly I would like to pick Dr. Devyani's brains. I'm sure the surgeons will get more this thing. I told my, we had a session on pleural effusion last month. And I very nicely said, my respiratory physician guy, let's do a thoracoscopy. And I called the patient from Dehradun. And he said, "Arey, jaun kahan se? Andar kuch hai hi nahi." So, you know, in our institute, they also they create a hydropneumothorax. That is also, I asked them to do. They were not able to do that. So, Dr. Devyani, your thoughts on this?
So with this kind of a massive effusion, with the ADA being what it is and repeated cytologies coming as atypical cells, and you also mentioned that the CT thorax showed some amount of pleural thickening. I wouldn't say for a lack of anything else, I think a thoracoscopy would be the next step in this case, which would help us inspect the pleural cavity, look for any suspicious looking lesions, and hopefully get a more representative biopsy.
So, Dr. Devyani, the ICD was already in place. The lung had there was no fluid really inside over there. Can you still do a thoracoscopy? I mean, for medical oncologists, you know, not so.
Yes, yes, you can. Yeah, it will be a procedure under general anesthesia. It won't be like a pleuroscopy, which could be done via an ICD. But
a surgical thoracoscopy.
A surgical thoracoscopy, like video assisted, the VATS procedure, it can definitely be done.
Okay. Doctor, I think Abhinav has spoken or Tanmay has spoken. I didn't get.
Dr. Abhinav has spoken, sir.
Yeah. So, Dr. Tanmay?
Sir, I would also, if the biopsy, pleural biopsy, which is suggestive of suspicious of malignant cells are present, if we can try for an IST from that, I think it might be of some help, even if there are not too much amount of crush artifacts or whatever like that. That I think we can try. We can have a try for that.
Okay. So my concern and doubts, and we needed a lot of help actually. And you know what I did? So we are medical oncologists, we are lung cancer people. What I did was so mesothelioma never came into my, honestly, mesothelioma did not come into my mind at this particular time. I sent a liquid biopsy EGFR. I took out the fluid from there and I sent it for NGS also. So, I mean, you know, a non-smoking guy, for me, the first differential actually was only towards lung cancer. And this is a real case. So I'm, you know, the next down the line, we had a liquid biopsy EGFR because I thought this will come positive and then maybe we can give the guy something over there, but nothing. So my doubts and concerns or my learnings that I want from the radiologist or the surgeon is, are there any radiological features to differentiate or point towards mesothelioma? Because I can show you a typical case like this, which presented as adenocarcinoma, which I showed in the last panel that I did actually.
So you're right, Dr. Ullas, it's very, very difficult to, very conclusively differentiate between an adenocarcinoma with pleural deposits as against a mesothelioma. But like Parang had said in this talk, really elucidated very elegantly actually that if there are nodular deposits and a very well-defined thickening of the pleura, which is going on the mediastinal pleura and the parietal pleura, and especially unilateral disease, no other lesions seen in the lung, then maybe you need to start thinking of mesothelioma. And having said that, even a history about the patient's workplace, any history of asbestos.
I will come to that, Dr. Devyani. Yeah. The workplace, I will come to that. Dr. Rakesh Kapoor, sir, does your radiologist actually report like this? It's very easy to say, you know, nodular thickening and all. I mean, all that they write is some amount of pleural thickening is seen. I actually checked the last 15 radiological reports, and I hope none of from my institute is listening to me. Nobody comments. I mean, that's my one. I mean, I'll ask Devyani and Dr. Rakesh Kapoor. Dr. Rakesh, sir?
Dr. Ullas, I think what Dr. Devyani has said, it is a difficult thing to comment. You have nodular deposits, but you can't immediately say whether it is a mesothelioma or not. You can't pinpoint it. It is difficult. But one thing is definitely there, our radiologists, they definitely try to correlate the history. Because, you know, in mesothelioma, most of the farmers, those who are working in the chemical factories, if you have that history, then they definitely pinpoint at the end and they write something like that so that the suspicion grows more to us, because in this region somewhere the asbestos exposure is there in the pesticides. It was there earlier. We did a study, I think Alok is here. 5 to 10 years back, we were a team from PGI, we all were together and we studied that in the water table of this area because of the free fall use of the pesticides through the helicopters in that area for the BT cotton. So we found that some of the patients, they came and we had a suspicion in PGI. But still it is very difficult. It is difficult because the presentation can definitely go with metastatic deposits as pinpointed. So you have to be very cautious.
True
But,
that.
and the exposure time is also very long. It can vary from 20 years to 40 years. So it is not easy to comment.
True that, sir. So, Dr. Devyani, any specific radiological modality or a CT or a PET, MR, something else, or a diagnostic contrast and CT scan is good enough, and a PET scan, as Gagan said.
Yes, so CCT thorax and a PET if diagnosis, nothing else over and above, nothing else.
Okay, fantastic. So my concerns, I think Tripti is there, who is writing some good points over there. Dr. Tripti, please come. And then my medical oncology friends over there. And is cell block good enough, Dr. Tripti? A lot of time, we have done a lot of studies in which the pleural fluid, if we make a cytology block and everything. So is cell block, and I'm being very honest, I'm here to clear off my doubts actually, rather than to conduct a panel discussion. So is cell block good enough?
So cell block is good enough. The only thing with cytology is that whenever there is sarcomatoid morphology, it is not easily shed off in the pleural fluid. So that is why we tend to miss. And usually in this scenario, like lot of reactive mesothelial cells, and you cannot histologically distinguish. So sometimes P53 and desmin, there are some markers, and TTF1 obviously. So in this scenario, even if very scanty atypical, but if it is highlighted by TTF1, you can clearly rule out mesothelioma. So
Okay.
So even if scanty cells, and with this kind of clinical scenario, markers like D240, TTF1 and CK7 would be helpful.
Okay. So again, Dr. Devyani, on this biopsy thing, so what happens is we do a lot of medical thoracoscopies and we do a lot of our respiratory people do. And they do a lot of, whenever you do a pleural biopsy, every time I do that, my pathologist will ask me, ring me up and say, "Isme mesothelioma to nahi lag raha," because we are seeing some spindle cells. Because whenever you take a biopsy or chunk from the pleura, you will obviously see some spindle cells. So what is your experience on that?
So thankfully, we are blessed with extremely good pathologists and radiologists both.
And so are we.
Like Trupti said, a lot of times on the cell block itself, they give us the report of a mesothelioma. And if not, more often than not, even a CT-guided biopsy from the thickened pleura yields a diagnosis. And the number of times we've actually had to do a thoracoscopy to go in, visualize and get a biopsy has been quite rare.
Okay.
But in the parts that we have had to do that, we've been able to actually pinpoint the more pathological looking pleura and the deposits there and get enough tissue for our pathologist to make a comment.
So Dr. Tripti, any pointers on the histopathology? Like I said, the spindle cells or something, which will, tissue is always the issue. If you want to save time and do this, or you have to do TTF1 and callit and everything.
Yes, we have to do. So initially high index of suspicion, imaging wise only pleural, no lung mass, because mesothelioma can look like anything under the sun. Any metastatic adenocarcinoma, metastatic carcinoma can look like it. So always we put like 2 mesothelial markers, and TTF1 is always there in the panel with this kind of scenario. And sometimes even sarcomatoid carcinoma, they have very low sensitivity. So that time only just some cytokeratin and D240 will help. Otherwise, it is very difficult for pathologists also.
Now, Dr. Tripti, a very relevant question. I'll ask my medical oncology people first, and then I'll take your comments on this. So the initial report, Dr. Mandal, comes as a poorly differentiated carcinoma, TTF negative, P40 negative. Why is this not NSCLC, NOS, and let's conserve the tissue, send it for NGS, Just forget this is a rare tumor panel discussion. If this was a normal lung cancer panel discussion in which me and Kumar were discussing, why is this not a NSCLC, NOS? So first of all, no, Dr. Tripti, you're the pathologist, you will have the last word. Fine, let me put my doubts first. So Dr. Mandal or Dr. Abhinav, anyone? Okay. The medical oncologist seems to have Abhinav.
TTF1 is negative, so it could be definitely NSCLC. Maybe we need to put furthermore markers for mesothelioma.
So, Dr. Abhinav, what I want to ask you is that in all the cases where TDF and P40 is negative, does your pathologist or you ask your pathologist to put a WT1 and calcitonin?
No, sir. Morphologically also it will help, sir. Morphologically, if we look, if it is more of like mesothelioma, like, then we might consider adding that. And
Tripti
still,
only said no. Tripti only said that it can look like anything.
sir, but if it's P40 is negative, then definitely I would ask the TTF1 is negative.
So my only reactions on this is, if I knew I was to become an oncologist, I would have taken my Father Robbins and my that Katzan book more seriously in my second MBBS. These are the only two books I didn't read seriously, and look what I have become. So Dr. Tripti, tell me, why is this not an NSCLC NOS?
Okay, fine. So whenever we do TTF1 P40 and decide our diagnosis, the first thing is that imaging wise there should be a lung mass.
Okay.
Just a second.
Lung mass.
Yeah. So there should be imaging wise there is lung mass. Now in this scenario, and before calling any tumor as NSCLC NOS, you should rule out. You should rule out any other sarcomas. You should rule out sarcomatoid mesotheliomas, hemangioendotheliomas, and only when you are sure it is some kind of carcinoma, that time give it as NSCLC NOS. So by default,
the CK would be what in mesothelioma?
So cytokeratin 7 is strong and diffuse in both mesotheliomas as well as in adenocarcinoma. So that is why it's a very high index of suspicion, and then you always put WT1 calretinib.
So exactly right, Dr. Tripti, and that is why we are also blessed, Dr. Devyani, to have great pathologists with us. So every time we have a diagnosis where P40 and TTF1 is negative, a call will come. Boss, lung mass hai ki nahi hai? Patient ki history kya hai? Asbestos hai ki nahi hai? And that is how they actually go and sign off the report. Again, hats off to the pathologist. I mean, the only thing that I could see in the pathology was a number which was written on the slides. Agar 36 hai to mesothelioma hai, 63 hai to adenocarcinoma hai. That's the only thing I remember from my second year MBBS actually. Okay, Dr. Mandal. Does your pathologist mention epithelioid versus non-epithelioid, and Dr. Kapoor or Dr. Devani can also come in? Do they mention regularly in their reports about epithelioid versus non-epithelioid mesothelioma?
Yeah, Dr. Ullas, they mention.
Okay.
They mention it is not difficult.
Fantastic. So Dr. Devani?
Yes, absolutely. They do mention.
Dr. Abhinav?
Yes, sir, they mentioned.
Okay. Dr. Gagan? Somewhere in max? Or you don't look, you have to give radiation?
This is not a very common scenario, but yes, once it's done, all the things are thoroughly mentioned.
Fantastic. So we
Dr. Ullas, can I intervene for a minute?
Aap aadesh karen, sir.
I'm very sorry. Gagan is already here. I just got a call from the medical superintendent PGA. There is some administrative urgency. So I'll have to take that. I think Gagan has already dealt with all the nitty-gritties related to radiation. So
the loss is only above, sir, but you please take care of your work. Thank you, sir.
I'll just, I have responded back on the phone call. I said I'll reach in 15 minutes to the hospital.
Not an issue, sir. I'm so grateful
give me that liberty. You know, it is a hard time in Punjab right now. The government shifting is going on.
Sir, all the best for that, sir. हम लोग भुगत भोगी हैं, दिल्ली वाले.
I'll take leave from all of you. Thank you so much. But I think Gagan has covered most of the things. He has given all the nitty-gritties on that.
No issues, sir. Thank you.
Thank you so much.
Moving forward, my doubts and concerns for the medical oncology people. And Dr. Abhinav and Dr. Tanmay, I would want some honest conversations. Saturday night, 2100 hours, even without a small patiala. Let's have some honest conversations. Okay. How commonly do you see mesothelioma in your practice? Everyone, Dr. Abhinav and Dr. Devyani and Dr. Gagan.
Sir, Dr. Tanmay here. It's not very common to see a mesothelioma. In TMH, still we used to see some, but in Kolkata, what I have seen in the last 1 to 1.5 years is, I think, some 2 or 3 patients maximum. Otherwise, I have not seen mesothelioma. And history of asbestos exposure, actually, I don't even ask for that much. It's an indirect way of asking. Means when the diagnosis of a mesothelioma comes, then only we go for asking.
No, but how many people, Dr. Mandal, do not have the asbestos exposure? I mean, I'll put my hand up and say, not many people at least in my setup, will give a history of asbestos or cement exposure. We don't get that actually. So that's my.
So we also don't have that much. No one gives a history of asbestos exposure in whatever 2 or 3 patients which have. No one had given a history of asbestos exposure.
Let me talk to Dr. Abhinav. Abhinav.
So yes, sir, as Tanmay sir said, we don't see. I've rarely seen. After coming out from TMH, I've never seen. Still now, I've never seen single case. Although recently I saw one case of peritoneal mesothelioma. That was also like it was query. So
okay,
it's very rare.
Dr. Devyani.
So being in tertiary referral center, we do end up seeing a couple of more mesotheliomas than we would otherwise, but very uncommon. So I would say for every probably 100 patients of non-small cell lung cancer, you'd see probably 1 potential mesothelioma.
Yeah.
And asbestos exposure, very uncommon. I mean, it's very difficult to pinpoint.
Okay, I think for the surgical oncologist, I will ask this very important question to Dr. Devyani first. The second one, how do you assess operability? You have said, but just for a nutshell, if you can tell. I struggled with the second question. Initially, I put, is it ever operable? Then I thought, is it ever inoperable? A surgeon, when a surgeon said it's never inoperable. So only if it's post-mortem or you can see the table from it's inoperable. So is it ever operable, inoperable, any point in doing an R1 resection?
Right. So operability, an operable mesothelioma, like this thing is more often than not a fit patient. So if the patient is not fit, all this discussion is moot.
Fair
enough. And secondly, it has to be something usually limited to the hemithorax. So anything which is going like beyond the diaphragm, looking like there are deposits on the abdominal side of the diaphragm. Sometimes we've seen liver being infiltrated or creeping across to the contralateral side, or heavy nodal burden. All these are no-nos as far as operability is concerned.
Pericardial involvement?
Is all right, because pericardial excision is actually a part of either of the 2 surgeries. So pericardial.
So what all do you take out? And my always concern is, what do you leave here? What happens after that? Tell me about that procedure. This is what I ask Dr. Darlong all the time, chhod ke aaye ho, wahan hawa hai kya wahan sab kuch? Then walk me through it.
So if it's an extrapleural pneumonectomy, then like you said, hawa hi hai andar, because you end up removing the parietal and the visceral pleura. The lung is gone, the pericardium is gone, and in most cases the diaphragm is gone as well. But if it's an extended pleurectomy decortication, which we are doing more and more and trying to do more and more, in that case, the lung is left behind. So everything
EPD.
else but the lung. Yes, in an EPD. Yes.
Okay. Gagan, how comfortable are you in giving radiation after that? Yeah, and where do you give radiation to? I saw you struggling actually on that. That was not a usual Gagan Saini which we normally know. You were thinking, kahin wo Saturday night ka sach wala baat aa raha tha na ki chhod dete hain.
So seriously, the dose that is required is more than 50 gray for any sort of control, and that too required to the entire pleura. And then with that lung in place after their decortication, the chance of pneumonitis is almost Devyani has done a decortication, then perhaps on the tumor board, I will ask them, that what is the area you are worried about? Where are you really worried about? So maybe that can be one approach.
No, but there is no point in giving one targeted radiotherapy to the one particular, no place. Gagan, that's what, in our tumor board also they say. It's a pleura, so you need to give it to the entire hemithorax, right? There's no point in giving it to one particular point.
I agree with you. It will be done on case-to-case basis. Suppose it's an extensive pleural disease with, which is stuck everywhere, and they could not do an EPE because EPE is toxic, and they have done decortication. Then there is no point in giving radiation there, because the kind of pneumonitis that you will end up dealing with is going to be very high.
No.
Can I actually ask you a question?
Can I just make a comment and then it's not the surgeon or the radiation oncologist, the medical oncologist who will have to bear the pneumonitis.
That's why I said you will be dealing, because later on you will be giving Nivo and Ipi also. So the kind of mess that gets created. So that is not the kind of case I would like to give radiation.
Dr. Devyani,
unless in the tumor board I find that. Unless in the tumor board, I find that, say Dr. Devyani is informing that, okay, fine, this anterior part was stuck, rest we have been able to do. So maybe there is no harm in giving, since you have already completed your chemotherapy, Dr. Ullas, and you are just waiting for recurrence to start your immunotherapy, no harm in giving some radiation if pneumonitis can be avoided with radiation. So that is the limited space. But yes, after EPE, where there is no lung and the chance of pneumonitis is less and the patient has recovered, I think we should go in for hemithoracic RT done in a proper way.
So Dr. Devyani, your comments.
My question to you here, Dr. Gagan, is the world is moving away from a pleural pneumonectomy to saving the lung as far as possible. And even the MARS-2 trial, if we see the protocol, the radiation part of it has been done away with completely. So if you have a disease where you have been able to achieve a maximal safe resection, so to say, with a pleurectomy decortication, do you still think of hemithoracic RT in such cases, or is that out of the picture completely?
As I just said that, it will be, if you're doing a pleurectomy decortication, I'm not keen at all to give radiation unless we are able to, fine tune our radiation to some particular point or the other.
Absolutely.
Okay. So that is nice. Please, if everybody 64 delegates were listening to us, read in between lines about what Dr. Gagan has said. Rest, I will leave it to your imagination. Dr. Devyani, it's okay, Gagan. I need to have 1 point above at you once in my lifetime. No, yaar. Okay.
You always have it. You always have it.
Devyani, after ICD, let's say you're going to go for neoadjuvant chemotherapy. Can I do my pleurodesis, or what about the
rather avoid it actually, because a pleurodesis incites an extremely fibrotic reaction which makes any future surgery fraught with challenges.
So let us say that Dr. Devyani, because time is limited, sorry, yaar, I'm learning from you. So let's say we have done a ICD, the biopsy report comes as mesothelioma. You ask us to give neoadjuvant chemotherapy. Then will the tube stay inside for 3 months?
No, it won't. Please remove the tube as soon as the patient's symptoms
so
are
that is the point which I wanted to bring out actually. That's what we do. We do take out the tube. So this is our tumor board, and this is during the tumor board, the COVID tumor board that we had. Surgery upfront, NSCT, I think we have discussed. I'll only answer this question. How many cycles, Dr. Abhinav? How many cycles of NSCT adjuvant?
So 3 cycles, 3 to 4 cycles.
3 to 4, I think. And we are also learning, moving towards finish all your chemotherapy prior. Don't wait for the surgeons and then give 1 cycle. The 4th cycle chemo never gets given. That's what the point is. You know what? Kabhi theek hi nahi hota to mushkil ho jati hai. It's better to give away all the 4 cycles. So this is a histopath report. Tripti, if she is there, this was the patient. Atypical cells were positive for CK56, WT1, calretinine, negative for all these markers actually over there. 3 cycles of pemetrexed. This was the PET scan report. This patient underwent surgery. Whatever. Dr. Devyani, just, and Gagan, just read this report properly. And this is the histopathology report. Important thing is, the pericardial cut margin is 1 millimeter away. It's an epithelioid mesothelioma, less than 50% of residual tumor. And the moment of truth basically comes with the parietal pleura is involved, lower lateral chest wall pe, and the nodule on the pericardium is involved. With this report, Dr. Gagan and Dr. Devyani, RT yes, RT no.
So I'd like to ask, I'd like to go back to the baseline imaging and ask that, this nodule on the pericardium, how...
No, we were not able to see. Not much.
So Dr. Devyani, what I will ask, of course, she was of course not involved in this, but I'll ask the surgeon that, what is the location of this nodule? I mean, what is the actual ramification of this presence of this nodule? Is it a part of the same?
When you do the surgery, Dr. Devyani, do you think you shave off? I mean, that's the word. Sometimes what do you do?
So in this case, your surgeon has done a fantastic job and has taken the pericardium oblong with the specimen. So I wouldn't really be very concerned. And as we say, we aim for a maximal cycle reduction in mesothelioma, which is more than achieved. So I would be comfortable not radiating this patient as well.
So, again, Dr. Devyani, asking you a very point-blank question. Happy with an R1 resection?
Yes.
In this case?
Yes.
No heartbreaks?
No heartbreaks.
Okay, Gagan? RT yes, RT no.
Wish-
No heartbreaks.
Wish we could give safe RT in a scenario like this, but since we can't, we shouldn't be doing it.
We also did not give. In fact, this patient is absolutely, I mean, so this is the story continues. We just finished with chemotherapy and gave. I have just for the purposes of this, I think I have told that the patient has got recurrence. The patient does not have a recurrence till now. It's been almost 2 years. I wanted to ask my medical oncology friends, immunotherapy in mesothelioma, yes, no? Abhinav,
Yes, sir.
have you given? I
No,
haven't.
sir.
Okay, and that's a good one. Dr. Mandal,
But the data shows, sir.
that data
Because
is good.
anyways, chemo doesn't have, like, it doesn't give so much benefit.
Okay. Dr. Mandal, immunotherapy, yes, no? Dr. Mandal has gone to give immunotherapy, I guess, already. Any biomarkers? Dr. Tripti is here?
Hi, yes, I'm there.
Yes.
But sorry,
You're
I
back
missed
from
your
your
question.
walk? You're
Yes.
walking somewhere. Wow, good. That's the fun of virtual meetings, no? I love virtual meetings.
Yeah. Sorry, I missed your question. I got disconnected.
Any biomarkers for mesothelioma, immunotherapy, any prognostic markers?
You mean like PDL1 and
Something
that?
of that sort, yeah.
Uh,
For immunotherapy. The long and short answer is there none.
yeah.
There's no
Yes.
biomarker, there's no role of PDL1. The only thing is epithelioid and non-epithelioid. People
Yes.
with non-epithelioid did much better. But I think the important thing which I wanted to bring about is Nivo EP had the same 18.6. In the epithelioid one, the chemotherapy did work better than the other one. So that is why the graphs are actually above. Otherwise, if you see 18.6 and 18.7 everywhere. So that is the thing. So my conclusion on mesothelioma basically are, first of all, thank you. Thank you actually the surgeons and the radiation oncologists actually and pathologists for helping us learn. I mean, honestly. And I hope I am able to keep the people awake at that particular time. So thank you. I had a fantastic time. Looking forward to meeting everybody in person. Thank you.